strategies to support the COVID-19 response in low and middle income countries. This is a special series that we've been doing twice a week for the last 3 months, and it's all archived. If you find it of interest, go to the website, Center for Global Health at Johns Hopkins, and there you will find all the archived lectures. My name's Tom Quinn. I'm the director of the Center for Global Health, and I'm very pleased today to introduce our two speakers. A good friend of mine, Justin Lessler, the associate professor in epidemiology and runs the Infectious Diseases Dynamics Group. He's a member of the Center for Global Health. He's worked internationally and his expertise is in infectious disease modeling, one of the first to publish on the median incubation time for SARS-CoV-2. And so he will be talking about modeling and forecasting the COVID-19. And joining him is his colleague, Kyu Lee, who's a postdoctoral fellow, also in the Department of Epidemiology, I should say both in the Bloomberg School of Public Health at Johns Hopkins University. And he works closely with Justin on these infectious disease dynamics. So we're really pleased to have both of you take on this talk, modeling and forecasting COVID. A very hot topic for every country, every county, every state, and so forth. So before they get started, I want to remind everyone, if you want to introduce yourself, say where you're coming from or where you're located, you can go to the chat box for that at the bottom of the screen. But if you have specific questions for our two speakers, please write the question in the Q&A. I'll be monitoring the Q&A box. So that's where the questions all should go. We're gonna let them speak straight. And at the end of their talk, we'll get into a dialogue on questions and answers. So don't be shy, put in whatever question you have. And without further ado, I'm gonna turn this all over to Justin Lessler. Justin.
Hi, thank you, Tom, for having us. And as Tom mentioned, Kyu and I will be talking about modeling and forecasting COVID-19 with an emphasis on the problems and challenges that come up when doing this in low and middle income countries. So there's an overused quote from George Box that says, all models are wrong, but some are useful. And while this is very true, it really begs the question, useful for what? What might we actually use models for? If they're tools, what are they tools to do? Slide. So there's a lot of ways you could chop this up, but I like to chop it up into 4 broad categories. One is theory, asking how disease systems behave under certain conditions. Sort of how do we understand the dynamic, complex, interacting system that leads to, that underlies disease transmission? And what do we expect from that just theoretically? But in a school of public health, we're more interested in things like strategic modeling. So how will some intervention work in controlling a disease? How well will it work in contrast to another intervention? Thinking of this strategic modeling as broadly, what are the critical scenarios we should be planning against when we're confronting disease? And it's important to realize this isn't necessarily the aim in it here isn't to forecast, it's to get good approximations that help us make policy and planning decisions. And this contrasts with, say, inference, where we use our mechanistic understanding of disease. And when I say models here, I'm talking about models that capture some of that mechanistic understanding And we take that mechanistic understanding of disease and use the fact we understand them mechanistically to understand the data better and understand how things are interact between them. And finally, forecasting, which is what most people think about when they think about infectious disease modeling, but I think is actually often the least important thing. It's the question of there is what's likely to happen in the future. And here in this talk, we'll be talking mostly about the strategic modeling and forecasting, and leave the others to the side for the moment. So here I show a picture of sort of an idealized view of a normal or of an emerging disease. This is from a paper I wrote with Jess Metcalf a few years back. And you know, you can think of there being a pre-emergent period, a emergence period over the left, and then disease emerges. And when it emerges, we have this sort of short-term forecast period that we can focus on. And then, you know, where the disease is merging and growing in the population and going up. I show here, this is sort of B here. And then there's this middle period where the disease is sort of getting established in the population and it's sort of midterm out into the future. And we're responding to disease, trying to recover it. And then finally, there's the sort of the long-term ultimate fate of the disease, shown here on the far right with D. Now, there's a natural analogy here to weather forecasting, where the short-term forecasts, they're like our 10-day forecasts. And just like in weather, where they can, you know, the 10-day forecast is pretty accurate, we can do fairly well at these short-term forecasts, looking 2, 3, 4 weeks in the future, projecting from current trends. We're not perfect, but we can do quite well, particularly if we have a good sense of the current situation. Likewise, you know, on the far right, I think, you know, thinking about the ultimate fate, that's equivalent to like climate models. You know, you don't know necessarily, you know, what the temperature is going to be next year or the year after that, but you know, if we continue, you know, dumping carbon into the atmosphere, that the temperature will ultimately rise. Likewise, we know some basic principles about how infectious diseases work. So for instance, if we know the disease causes permanent lifelong immunity, we can sort of be sure that eventually it will become an infection of, you know, younger people or children without a vaccine given time. But how long that will happen and what will happen in between, that's the really hard part. And that's kind of where I think we get to the farmer's almanac part of infectious disease forecasting. Like, you know, just like the weather can't really weather forecasts can't really tell us with any great accuracy with whether or not it'll be rain on the third Tuesday in August. We can't say much with accuracy about that midterm time if we're thinking about real forecasts. And it's even harder for doing infectious diseases because unlike the weather, where the weather sort of happens, at least in the short term, regardless of what we do, infectious diseases react to our actions. And in fact, a forecast of infectious diseases can actually change what happens in the future. Next. And of course, I'm not going to talk anything about the pre-emergence period, but that's kind of like Nostradamus' prophecies. So one thing I'd like to say about forecasts in general, and when I talk about them in general, is like, you should not believe any one model. Like, and this includes our model that we're, you know, our group is doing at Johns Hopkins. You know, and this is the way we do hurricanes too. What we do and weather forecasts too is we take a lot of models and we look at them together and we look at the ensemble and the combination of their results, and then we project out from that combination of results rather than just picking one as the best. And every time you see a hurricane forecast or get your 5-day weather and stuff like, or something like that, those are all based from ensembles of models. And Hopkins alumni, Nick Reich, has been bringing together the models, a lot of models on his forecast hub and doing exactly this. And this is stuff that's been reproduced in 538 and CDC, at CDC. So his ensemble model, next slide, has been quite accurate, and it's shown here in red. And you can see, for instance, that it's a bit more conservative than our model, but because it's averaging like models that are projecting curves and stuff like that, with our model that's really heavily driven by the policy decisions that given communities are making. So actually tends to be a little bit aggressive about like how bad things are going to be when they're moving up. Next slide. So that's forecasting, but forecasting, as I said, isn't the only use of models. And when early on in the pandemic, and I think, you know, still quite useful, is to focus on planning scenarios, not forecasts. And so what's the difference? So the idea is that we want to focus on scenarios relevant to planning decisions and get rough approximations based on our best knowledge of the dynamics, the current situation, and severity, to give sort of these midterm projections of what might result from different policy decisions. And I think the key here is that the focus is more on, will often be more on the differences between these various decisions rather than any particular single number, absolute number. And this, though we may be concerned with, like, you know, the probability of overrunning ICU bed capacity and stuff like that, but it's because we're trying to inform decisions, and it's not necessarily, you know, it's not necessarily critical to get that next 4 weeks perfectly correct, as long as we can broadly get the differences go over time. And we use a pipelined approach to doing this, and I want to go into this just a little bit because I think it's somewhat relevant to some of the challenges that come up when we try to think about moving this model, this broad model, this framework, to low and middle income countries. So our model that we're using in the United States and in other and outside the United States as well is this scenario pipeline model, and we're really taking a modular approach to try to make it easy to drop in and out pieces as we learn more about the disease, or people find improvements, or we need something different for a particular setting. So it starts with a model seeding, which early on was based on international flights and external epidemics, and now has become more based on early case reports. And then that feeds into an epidemic generation engine, which that is kind of what most of you probably think about more classically when you think about an infectious disease model, something that takes the way we understand disease transmission and transmission dynamics and generates cases. And that's going to be based on like our assumptions of how the disease works, our observed data, and the intervention scenarios we can lay out. And then we take the infection counts from that and we run it through a hospitalizations and outcomes generator, which uses our assumptions about how severe the disease is. We can look at like different scenarios for those assumptions, looks at adjusting hospitalization rates and stuff like that by the age distribution of the population and things like that. And then finally, all of that runs into a report generation. So, you know, we take this engine and we use it to consider scenarios. And to give an idea of what scenarios might look like, here's 6 we used in an analysis we did for Maryland about a month or so back. You know, and these are going from 1, which is just continued stay-at-home measures with declining adherence. It's basically was saying we do the status quo, but people are increasingly unlikely to follow it. And then, you know, so in a way, even though it sounds strong, that was our weakest intervention. And then we go through from roadmap to recovery, people doing self-isolation and quarantine, all the way through to the most extreme measures, which include social distancing, a lot of manual contact tracing right off the bat, and household isolation of cases. And we used data from analyses done by other groups in our review of the literature to sort of parameterize these and get projections of what how each would play out into the future. And so we get results like this. So this is showing, and we're not going to go into this in a lot of detail, but it's just showing all of the counties of Maryland and projecting out the number of ICU beds needed, and whether or not under that scenario we clear the number of ICU beds. We need more ICU beds that are available in that area. And I think the message here is, based on the information and assumptions we made at the time we did the forecast, only the most aggressive control measures that I should emphasize fall short of the type of stay-at-home measures that we've done, that we've been doing in the past. Only the most aggressive control measures were ever keeping you below ICU bed capacity, based on what assumptions there. So this all begs the question: so this is a nice framework. It's useful in some sense, but it begs the question: does any of this translate to international settings, particularly low and middle income countries? Or rather, what is different? What do we have to think about differently when we try to move this work into those settings? And with that, I'll kick things over to Kyu.
Okay, thanks. So to dive into this question a little bit more, we wanted to use an example of a country, Bangladesh. And we've been working on creating models for Bangladesh for a few weeks. And we've encountered a lot of challenges along the way that are quite relevant for other LMICs. So to give you a brief background, the first confirmed case was identified in Bangladesh in early March. And that's in a period when testing wasn't as regular. And since then, testing has ramped up, and we're identifying thousands of cases each day. And right now, I believe the total is above 115,000 reported cases and 1,500 deaths so far. So when you start thinking about, how can I adapt this model to a low or middle income country such as Bangladesh, what are the different components of a scenario planning model? And the first question that pops up is, do we even have the data to start inputting into this pipeline? And I'm going to go through 3 of the different components here and discuss the challenges that we encountered and some of the solutions that we came across. So if we focus first on this model seeding component, this is, again, just a reminder, this is where we are introducing cases into a country. And as Justin mentioned, in the US, one of the sources of data that you could use is international flight data, right? We can use that data to approximate where these introductions are occurring. One of the assumptions that are used there that works for the US is that we can assume people that are arriving are going to stay in that general area for an extended period of time. But let's think about airports in places like Bangladesh, where there is one primary international airport in Dhaka, and the individuals that are arriving are not necessarily staying in Dhaka, but returning to their home communities, which may be hundreds of kilometers away. So that kind of data might not be relevant for Bangladesh. You might even think of, let's use some early reports of cases in Bangladesh. But again, if testing is poor in the beginning, and cases are underreported, that seeding step can be quite difficult. The next component you can think about is this epidemic generation step. And the goal of this is to really capture the spread of the epidemic. And to do that, we need to understand mobility patterns in that given country. So in the US, there's some great data resources that you can use, such as the census, which includes daily commuting data. So you have a better understanding of how people are flowing in and out of different geographic regions. But is that kind of data available in places like Bangladesh? And the first thing we discovered is no. And the general idea of commuting is so different for places in LMICs. So what we ended up doing is start to look at all the projects that we have ongoing there, reaching out to colleagues there just to try to find any type of data that we could use to better understand mobility patterns. And we ended up actually arriving at a study that was conducted for dengue, but a part of that study included this travel surveys that were, and this travel survey was conducted nationwide. So we were able to use that data and input it into this scenario pipeline and to better understand the spread of the epidemic in Bangladesh. And we can also think about this from this hospitalization outcomes component. And really, it's important to consider these outcomes that we're looking at. There's a lot of assumptions that make sense for high-income countries or upper middle-income countries, but are not necessarily relevant for low-middle-income countries. For example, if the purpose is to show the hospital capacity that you need, one of the major assumptions that you're using in this model is that individuals that are severely ill will seek care. They'll go to a hospital if they need. Well, realistically, like in places like Bangladesh, a lot of severe infections, individuals with severe infections will not go to a hospital. They'll actually stay at home because a lot of the care provision is provided by immediate or extended family members. There's also assumptions about ICU quality. Right? If you run these models for high-income countries, the assumption is that there is this particular standard of quality provided for ICU patients. But is that the same for low and middle-income countries? There are assumptions about ventilators. Are individuals that need ventilators given ventilators? And the reality is there are not that many ventilators in places like Bangladesh. And it's really important to start thinking about the assumptions that are placed here and how that's going to impact our estimates of mortality and transmission. And this really gets to the questions of what's really the point of giving a forecast. Anyone can tell people how bad things are going to be in a given country. And the reality is that even helpful? And no, it's not. It doesn't help our colleagues in Bangladesh to simply show a forecast. And that shows some of the advantages of strategic modeling. As Justin mentioned earlier, it allows us to look at the relative impact of different interventions. What can we do to minimize harm? How will these actions, how many deaths will we avert by practicing different actions? And when we start thinking about these scenarios and these interventions, we need to consider whether they are even practical or realistic for low and middle income settings. A lot of models that you will see in the literature are looking at common interventions such as social distancing or isolation of cases, quarantining of close contacts, elder shielding. And while these may work in high income or upper middle income countries, we can look at Bangladesh as an example again and see why that's impractical. We're talking about a country that's highly densely populated. The capital has over 20 million people living there. We have households where the entire household will reside in a single room. And often the household will consist of intergenerations, right? The grandparents will live in the exact same room as the children. So when you're suggesting these interventions that are saying, so you should practice social distancing, you should try to isolate cases, you should try to quarantine close contacts, it really isn't realistic. And we need to think outside of the box of the different activities we can do to mitigate the impact of COVID-19. So with that said, we wanted to bring up some of the models that are out there for LMICs. And there is this major effort by places like the London School of Hygiene and Tropical Medicine. And it's an incredible effort because they're trying to provide modeling support for low and middle income countries, which is obviously a gap right now. One of the disadvantages of this is that they are using this one-size-fits-all approach. And even though they're creating these individual reports for most LMICs, they're ignoring a lot of the setting-specific differences. The figure shown here, it's a lot happening, but the different colors show different scenarios, and they're showing various outcomes over time. And the positive about this kind of model is that these are living documents that can be adapted to consider new information. But one of the things we wanted to point out is the scenarios on the right side. It's a little difficult to see, but a lot of the scenarios that they're proposing across these LMICs are, again, not really realistic for countries like Bangladesh. So things like social distancing, things like extended lockdown, things like elder shielding, right? These are really not relevant to places like Bangladesh. But another way to think about it is let's step back and actually focus on these differences in low and middle income countries. How does the income setting of a country change the characteristics, the demographics, the contact patterns? And so this figure here on the left shows how the age distribution is different depending on the income setting of different countries. The figure on the right shows how even if you have fewer elderly individuals in low and middle income countries, they're more likely to be in contact with more individuals of a larger range of age groups. And that has a lot, these differences are going to impact the attack rates across different age groups. Another factor they explore is healthcare availability and quality and how that differs across income settings. So what they arrive at is that they say low and middle income countries have fewer hospital beds, fewer ICUs, fewer mechanical ventilators. And this is all going to lead to higher infection fatality ratios, right? So the assumptions that we're using for high or upper middle income countries, those infection fatality ratios are not exactly correct for low and middle income countries. I would say the only major caveat of this paper is that even though the comparisons are really, really useful, especially for others who are trying to develop these country-specific models, the scenarios they consider in this paper are quite pessimistic. So this figure is quite busy, but on the part that's really interesting is E. And what they're showing here is in order to maintain ICU demands below 50% of the capacity, they're suggesting we need to do intermittent interventions for a long period of time. And is that necessarily practical or useful for LMICs? And it's quite arguable. And the overall message is that, yes, there's so many important differences based on the income settings of different countries, and these differences matter. And let's use this information to create better models. So before we end, I really wanted to talk about another really important factor for low and middle income countries, and that's indirect effects. So a lot of times when we create these models, we try to identify interventions that is going to be the most effective at reducing the impact of COVID-19. And for low and middle income countries especially, we're proposing these long periods of pretty restrictive interventions. And it's really harmful when we ignore the potential impact that has the other health outcomes. And a lot of my work right now in Bangladesh is related to child and maternal health. So when we think about the pandemic, we're imagining the impact it has on things like routine child immunizations, access to health services, what happens when you reassign regional healthcare facilities to specifically target COVID-19, what happens when you reassign community healthcare workers from what they were doing originally to the COVID-19 response. And I included figures from two different papers here. The figure on the left is a recent paper by colleagues here at Hopkins who show that just by small changes in the coverage of healthcare, it's going to have these major increases in excess mortality for both maternal and child, both in terms of maternal deaths and child deaths. The fun little figure on the right is from an earlier paper that I believe Justin was in part of. And what they did here is they looked at the disruptions that occurred during the 2014 Ebola outbreak in West Africa. And they predicted the number of children between 9 to 59 months of age who are becoming susceptible to measles because of these disruptions in immunization. And when these disruptions occur, it's going to lead to increased risk of major outbreaks of the other diseases such as measles. And so again, when we design these scenarios, when we think about these scenarios, it's really important that we think not just about how that's going to impact COVID-19 and the morbidity and mortality affiliated with that, but also these other diseases that, and I've only just mentioned examples from maternal and child health. So in conclusion, models can be incredibly useful, but from those individuals who are creating these models, we really need to dive in and think about the differences in these settings, the assumptions that we're using, the data that we're using, and how that's going to influence the outcomes that we're creating, the reports that we're creating. We really need to consider these indirect effects, even if the interventions that we're proposing are created with the best intentions. Let's think about the potential harmful effects that could have on other parts and other health outcomes. And with that said, I wanted to make sure that we show appreciation for everyone in this ID Dynamics COVID-19 working group. It really isn't just the efforts of a few people. It's a huge team that's working together and really discussing the challenges that we've come across when we're trying to develop models for low and middle income countries. And you can see this group consists of individuals from various different affiliations. And that is the end of my talk.
Justin and Kyu, thank you very much. Very timely and really quite important. And I think it was great the way you two broke that up with Justin, taking us into modeling, building, and the derivatives of that modeling and forecasting, both its strength and its limitation. And thank you, Kyu, for going into Bangladesh and giving that as an example. While you were talking, both of you, I was thinking, how would you go about doing India, the most populous country? And the news is really covering it right now, that this epidemic's really expanding quite a bit. You can address that if you want, but let me jump into, there's a couple of questions that have come in from our guests. And the first one is regarding Afghanistan. And let me just read that. There's been limited testing capacity and hospital capacity, and the total number of cases diagnosed has reached over 30,000. Unfortunately, testing's been limited in a way. The test positivity rate has only recently declined from over 50% 2 weeks ago to 30%, 34% yesterday. They've got a ways to go to get down to 5%. How can the country estimate the total prevalence of COVID-19 then, when you have that kind of limited testing? And how can one estimate the number of deaths that have occurred? I'll open that up to both of you for that one.
Yeah, I think this is going to be, I mean, ultimately, like the real answer is we're going to be studying this for 3 decades, both because the disease will still be around by some form, but also like these questions are going to be really, really hard to answer for places like Afghanistan. Like in the US, for instance, or even more so in some European countries where we have pretty good death reporting, I feel like death is the most stable indicator that you can sort of start backing stuff out from, short of a serosurvey. And we've all seen that even the serosurveys can have some major problems. But the, you know, but even here, like, right, we're getting better at treatment. You know, different populations are infected or impacted at different times. So it's difficult. So I think it's a very hard, it's a very challenging bit to do for a place like Afghanistan. Particularly too, like even there, I got, you know, even there, I think it is like this decrease in the number of tests positive, right? Is that because cases are going down, or is that because they're getting better at testing and able to test more people, right? And so it's a big challenge. And I think, you know, ultimately for situations like that, we're gonna need to take a multi-pronged approach. You know, we're gonna need to take areas with better surveillance and better testing and better death registries and use data from there. Take serological surveys that we can potentially piggyback on vaccination campaigns and other, evaluation and other bits and use that as well. So I think it's going to be a hard question, and it's not going to be one that's going to be answered, immediately.
Bill Moss, you had mentioned the sero surveys, and Bill. Bill Moss is here at Hopkins. How important is the forecasting scenario modeling to have an estimate of the true number of infections, both including asymptomatic and minimally symptomatic, those that don't get hospitalized? That can really only be measured through sero surveys.
So it sort of depends on the question and depends on where you're going. It depends on the question and the time frame, right? If you want to know the probability of a resurgence given your current state, it's extremely important to know that. And, I think Bill mentioned sero surveys are great, but also deaths, I think are also a good indicator, since to the extent the infection fatality ratio is sort of vaguely known and somewhat stable, given an age distribution. But the one thing I'd say is that, we have even a bigger unknown with this virus when it comes to making those kinds of scenario models, and that is it going to offer permanent immunity? The other widely circulating human coronaviruses don't, at least not on a single infection. And so that is one of, I think, because this one causes more severe disease, there's some reason to think it's more likely to, but until we know that, I think, that's going to be one of the biggest questions going forward about our ability to control this virus.
Yeah, and I'll just add, I do sero surveys, and so I monitor that type of information daily. And we will do an update on sero surveys, but I will say that at a minimum, 10% of people who have been known to be infected lose their antibody in the short term. So you do a sero survey, you may not pick those up. There's one paper in Nature Medicine just came out, up to 40% of asymptomatics lose their antibody. Now, again, it's asymptomatic. So the sero surveys are going to have their limitations, and how you plug them into these projections is going to be problematic.
Right. And it's not even clear, right, losing the antibodies, right? We know multiple diseases where you stop having the threshold of antibodies, but a lot of people are still immune, right?
Yes, correct, because their T cells have been primed and all that. There's lots of different things. Well, we'll get into that in our future series. Chris Hilbrunner said, is Hopkins producing forecasts for LMICs? I take your point about the shortcoming of the London School approach, but there are a few groups producing models with a wide range of the LMICs. And what about Imperial College or WHO modeling for LMICs? Q, I don't know if you want to take that one on. You're muted.
All right, so Hopkins is working on developing, again, these are scenario models for international, like other countries. But again, like the point of the highlighting the LSHTM model was not to necessarily criticize their work. It's definitely a major gap right now in COVID modeling, but to help pinpoint some of the shortcomings, right? And what can we do better to make sure that the models that we are creating are better models, right? Or just trying to improve them.
And we've been and people affiliated with our group have been doing models like particularly for refugee camps and which are largely in LMIC settings, and some work with Zambia. So we are doing work at Hopkins.
Yeah, I guess they may be asking as well. I know you are, but are any of them being published on a web that they could look at the way the London School does, or
So we take a little bit different approach. Like you'll notice, for instance, we didn't show anything about like particular results about Bangladesh, and that's because the approach we've been taking is to try to work really closely with partners, and a lot of partners and public health agencies really prefer you keep those those back and forth private.
Yeah.
They want to have control of who it's released to and what it's released to, and so even when we don't have a formal agreement, where we tend to take a little bit more of that approach. For better or worse, I think it's probably good to have both out there.
Okay. You might explain, what is an Arima model? Is it possible to use an Arima, I may be saying that wrong, to forecast local COVID and LMICs?
Arima models are decent Arima models are just autoregressive models that are kind of looking at current trends and maybe using some underlying information. But they tend to be decent for the short-term forecasts, but because they don't, at least inherent, like not by design necessarily capture any of the underlying mechanistic understanding or disease dynamics, I think once you get out past a few weeks into the future, they're not particularly useful.
Okay. Any work at this point with Brazil in modeling? How flexible are these models to cope with an ever-changing political landscape that they're facing right now? Are they still valid? So whenever you throw politics into the question, it starts to get quite difficult.
Right. I mean, this is the thing when people have asked me about longer term forecasts, this is the thing I've tended to say is like, if you can forecast the politicians, I can forecast the disease. Or forecast or at least forecast people's and way people are interacting. We haven't been working, our group hasn't been working directly with Brazil. I do think our model, the one thing I would say is our approach, our pipeline is sort of well designed for dropping in and out different policies very quickly and considering a broad range of policies. So I don't think it's a bad choice for doing that. But
yeah,
just to add, for Bangladesh, it's the same scenario where new policy actions are implemented in real time. And what's great is that as we get feedback, we can modify these models to consider these changes and interventions.
Are we doing that in the United States? I mean, so this is a loaded question, but I'm just going to throw it out there. There are a lot of US folks online as well, even though this is targeted more for LMIC. But the White House is using a lot of different models, as you know. Justin, you mentioned the Ensemble model, which it was sort of new to me because I don't do a lot of modeling. And I thought it was a great idea, pulling those models together and just doing it like you do hurricane forecasting. I thought that was a good analogy. Mm-hmm. But from your perspective right now, watching what happens in the US, are we following an Ensemble model, or are they still going by the model out of University of Washington or whatever? Debbie Burks is a very strong data-driven person, and so I know she's looking at the models all the time.
I guess two comments on that. One is, right, like I think from, nationally, right, like the United States is not one health policy, health policy, right? It's 50, and really many states it's another 50 inside them. But that being said, like also we're working with APL and engagement with FEMA, so I really can't comment on things related to that.
No, that's fair. Let's see, other questions here. Anything on Latin America? Have you worked with anyone in Latin America regarding? We just talked about Brazil, but any others? Mexico, South America, others?
We haven't much. I mean, to be quite honest, our bandwidth to help got overwhelmed almost immediately. right?
Yeah.
Like we started working on like COVID stuff, in late January, and by February we were sort of overwhelmed, and in March it was like a huge surge. So we're trying to figure out how to say yes, and I'd say all of the pipeline and everything we've presented is open source and publicly available on the web, and uses, so none of the underlying machinery, while the details of specific engagements might be private, all the underlying machinery is public and open source. And we've had several, for instance, states in the United States and some countries go and like implement the model themselves. But we have not been able to, just because of bandwidth of people to run the model and make sure that it's used in a useful way, we have not been able to take as many engagements as we'd like.
So I don't know if we can open the mic for David Peters. David Peters asked, I don't know, can we do that, Megan? Can
Sure,
you
I'll go ahead right now and allow him to talk.
see if he's on? Yeah.
I am indeed on. Another great presentation, Justin and Kyi. That was great. I had a question. It's from Bangladesh, but it's more general. Bangladesh, and the general question is, what is your approach to working on scenario planning when you have governments or agencies, parts of governments that really oppose their publication and public discussion? Early on, Bangladesh government did not want to really discuss this publicly about the COVID trends. And there was some modeling that our faculty were involved with that was released prematurely. It wasn't even finished. And it got really a strong negative response from government, not because of the results, but that it was published at all. And that it as you said, it created a problem showing how bad it could be, because of course they used the the no intervention scenario as a worst case. So the question is, how are you working with the government of Bangladesh in this case now? They also came down really hard on the local universities that were involved with that. So how has that changed in terms of your relationship, and how do you work with modeling when you have those kind of those variable kinds of responses and interests in government? Thanks.
So I'll kick over the Bangladesh specific to Kyu, but our general approach, as I was saying to Tom, has been to very much take the lead, or to follow the lead of the governments we're working with, and try to work within the systems, and try to find partners within the government. And a lot of times that means keeping a lot of stuff private. I think if we ever had anything where we felt like we had an ethical obligation to make it public, I think we would step outside of those relationships. But for the most part, we really, I think really try to smooth that over by being very much letting our partners take the lead. And Kyu can talk a little bit about Bangladesh in particular.
I mean, I absolutely agree with you, and specifically for Bangladesh, is exactly the way it's working as well, right? I don't see how it's any different for Bangladesh as well. And I do agree, in the beginning there was a lot of, I guess, conflict with that kind of what you pretty much mentioned. But even now you're seeing that at the main government website now, they are publicly sharing that case information. And so it's definitely changing over time, but I agree with Justin. What he just mentioned is very applicable to Bangladesh, and that's how we're following it as well.
So, Megan, I don't know if you can open the mic for David Bishai, another professor at Hopkins, but asking very relevant, important question.
And this will have to be my last question. I have this on my calendar for a different amount of time, so I'll have to jump off after this, but Kyu can stay with the Wolves if he feels like it.
I have that same meeting, Justin.
Yeah.
Oh,
that's right. Wait, you guys have been fantastic. Is David on the line, or we can drop him and go to one of the other questions?
I don't know. Can you hear me?
Yeah, we can. David, you're on.
Okay, so a lot of our countries are neighbors to countries that are not doing as good a job in a lot of our counties and states in the US. So I was just wondering if the epidemic generation engines take into account that your neighbor is having different policies and different intensities of the epidemic.
Right, so we didn't get into the details in the model, but it's a spatially explicit individual-based SEIR model that goes down to whatever spatial scale you have appropriate data on. So in the case of the US, we do that we model down to the county level. Outside of the US, I think it's been more like province level, but we model regionally as well when we can, because like you say, both within a country and between countries, the neighboring epidemic matter. And we also have the seeding engine doesn't just necessarily impact the early part of the epidemic, it can give impacts throughout the epidemic and uses up-to-date international flight data and epidemic data to seed infections in throughout. So we're very aware of that spatial component, particularly early in the epidemic, being a critical part of the whole of the story. And we, that the model is really designed around trying to capture those types of spatial heterogeneities.
Great. I think we're going to end on that note because both Kyu and Justin have another meeting that was scheduled. So I want to thank both of them on behalf of the Center for Global Health and thank everyone for joining in. I'm going to excuse the two of them, let them drop off. I'm going to ask Megan or Bodke. As far as next, we're going to have another one of these series on this coming Thursday. Can you announce that for me?
Correct. Yes. So on Thursday, we are going to be hearing from Dr. Anselm from PAHO, as well as his colleague, Dr. Silvana Luciani. They're going to be speaking about NCD management during COVID.
Absolutely great. Thanks. Thanks, Megan. We'll all see you on Thursday, and I want to thank everyone for tuning in. That was a great series today. Very important modeling and forecasting will continue.